This is just an overview of how the normal circulation looks like and how it looks like in a univentricular heart. As you all know, the left ventricular pressure comes down rapidly as it passes through the systemic venous circulation into the right atrium, and then it again goes, the pressure goes up a bit in the RV, then again as it goes through the pulmonary circulation to reach the left atrium. Left atrial pressures are slightly higher than the right atrial pressures and then goes to the LV and back to the aorta. So what happens in a univentricular heart is that the single ventricle is pumping against two circulations, both the aorta as well as the pulmonary artery. So the ventricle is significantly volume overloaded. So this was how Fontan circuit initially looked like when Fontan initially started doing it in 1971. As you can see in the lower figure, you can see that superior vena cava was anastomosed to the pulmonary artery as a classical Glenn, and then the IVC was connected to the left pulmonary artery through a aortic homograft. Subsequently, it has undergone a lot of evolutions through a lateral tunnel Fontan, through a classical Fontan where the right atrial appendage is anastomosed to the pulmonary artery, to the lateral tunnel Fontan, to the extracardiac Fontan. So what happens when you convert a univentricular circulation to a Fontan circuit? So a volume overloaded single ventricle immediately becomes a volume deprived ventricle. As you can see, the the systemic circulation no longer goes through a subpulmonary ventricle. It goes straight into the pulmonary arteries, so that the systemic venous pressures are on par or higher than the pulmonary artery pressures, which means that there is raised systemic venous pressure. And as you can see, of course, as you can all deduce, pulmonary artery resistance is the bottleneck to this circulation. So the thing that we should understand is in a normal person at rest, the cardiac output doesn't fall until the LV ejection fraction falls very low, that is maybe beyond 40%. So what happens in a Fontan? In a normal Fontan, in a perfect, so-called perfect Fontan, the circulatory output is 70% of that of a normal person, even in the best of conditions. And as you can see, it is all pulmonary vascular resistance driven. The higher the pulmonary vascular resistance, the worse the Fontan candidate performs. So essentially, the person is running in an autopilot mode, and the heart is no longer controlling the pump is no longer controlling the cardiac output. So there is a steady increase in central venous pressure, pulmonary vascular resistance, ventricular filling pressures, and progressive decline in flow as the patient passes year after year, as a patient completes years and years after a Fontan circuit. So eventually, what we understand from this is that eventually all Fontans will fail. So either it can be pump failure, which is actually less common than a pathway failure. So pump failure can be due to reduced ejection fraction, AV valve regurgitation, or problem with the coronaries. But pathway failure is much more common, where there is a problem with the surgical venous connection, the pulmonary arteries or veins, and much more commonly rising pulmonary vascular resistance. Organ failure can happen, which is called a Fontan with a normal ejection fraction, presenting with heart disease, liver disease. So organ failure, lymphatic failure, and electrical failure can happen. So why does this PVR keep on rising? So even in a normal individual, as they go on to the 6th, 7th, 8th decade, slowly the PVR rises. But it does so much more earlier in a Fontan, and it has got much more deleterious effect in a Fontan. So this elevation in PVR has been proposed to be due to the prolonged exposure of the pulmonary vasculature to a non-pulsatile continuous flow. So how do we then choose an ideal Fontan candidate? This was what Fontan and Chauset and other colleagues formulated in 1978. So they felt that if all these 10 commandments were fulfilled, you get a so-called perfect Fontan candidate. So age, they postulated 4 to 15 years. The patient should be in sinus rhythm. There should be normal drainage of systemic veins, normal volume of the right atrium, because initially it was done through a atriopulmonary route. Mean pulmonary artery pressures of less than 15, pulmonary vascular resistance of less than 4, ratio of PA diameter to aortic diameter of more than 75%, normal LV ejection fraction, no mitral valve insufficiency, and no impairing effect of a previous shunt. So even then they realized that the outcome was dependent on unobstructed pathways throughout the Fontan, intact pulmonary vascular bed, a low transpulmonary gradient, and a preserved ventricular function that translates to low end diastolic pressures. So, as years went by, people started finding ways to overcome the hurdles caused by the Ten Commandments. They started doing fontans much below 4 years of age. They also were forced to do fontans after 15 years of age. They found ways to do fontan in patients who were not in sinus rhythm by pacing. They could surgically correct the systemic venous drainage, and right atrial volume no longer mattered because everybody started doing extracardiac fontan. But still, mean pulmonary artery pressures, pulmonary vascular resistance, and to a certain extent, good ventricular function still continued to be basic requirements for a fontan to be completed. So, as I mentioned earlier, almost any PA distortion could be corrected by catheter or surgical preparation. You can see that pulmonary artery venous malformations are being coiled, aortopulmonary collaterals are being coiled to prepare this patient for a proper fontan. So next question is, so once you've made the conditions as perfect as possible and you've done a so-called perfect fontan, does it remain perfect? You see, this was a review, systematic review of a lot of articles that did study on long-term outcome of fontan, and what they found was that the survival rate under optimal conditions after a perfect fontan was predicted to be 73% at 15 years after surgery. So 15 years after surgery would translate to the patient being around 20 years of age. So at 20 years of age, you expect an attrition of around 25 to 27%, which is quite high. So now we come to the question. So instead of being halved, have the 10 commandments been doubled? So now we acknowledge that even mild degrees of aortic obstruction have to be tackled. Even mild to moderate AVL regurgitation has to be tackled. Any mild branch PA stenosis have to be addressed. Aortopulmonary collaterals have to be addressed. And any abnormality of rhythm, even if there is no ventricular dysynchrony, have to be tackled. So then we should look at all the modifiable risk factors, because there are a lot of non-modifiable risk factors like ventricular function, ventricular RV morphology, right isomerism, elevated PVR, older age at presentation. So then we are left with a lot of modifiable factors like AV valve regurgitation, PA size, rhythm, outflow obstructions, venous drainage. You have to optimize BMI. You have to make the patient aware about proper exercise. Though we feel that once a fontan starts failing, we can buy some time with a fenestration. Fenestration is not a substitute for pathway obstruction, and any pathway obstruction has to be aggressively treated. As in this case, the fontan circuit has been stented as well as a fenestration has been created. So, like Madam Snehal Kulkarni Madam mentioned before, you should not select such patients. Like you can see that the pulmonary artery branches are abysmally, dismally small. The second one shows a non-confluent pulmonary anatomy. The third one shows severe peripheral branch stenosis. So know your limits, know when not to push for a fontan surgery. So finally, it all boils down to one single commandment: thou shalt be perfect. Try to be as perfect in your patient selection as possible. Anticipate all problems that the patient may come across. Optimize all parameters. Use pulmonary vasodilators early and aggressively. You can try multi-site pacing and treat more than mild AV valve regurgitation. Optimize branch PA size. Thank you.